is coming through the bladder. There might be an obstruction here. As a result, it would be dilated and filled with urine. It looks like a cyst within the bladder. Okay, it looks like a cyst within the bladder. That means cyst within the cyst. Cyst means big cyst is the bladder. So this is bladder and this is ureterocele. Why this ureterocele is developed? Because the urine failed to released into the bladder. As a result, it gets dilated with the pressure. Ureterocele. Now I will discuss about the stone. Stone in the bladder. Or calculi. Keep that in mind. This stone and the calculi. Usually the bladder does not develop stone. Then what does it come from? It comes from kidney. Okay, stone and or calculi, it comes most of the time comes from kidney. Comes from kidney. Then it stay in the bladder and getting it bigger. So now, if there is a stone in the kidney, how does it look like? How I'm going to know this is a stone? What are the property of bladder stone? Sonographically, if there is a stone, so you will see, say this is bladder, and if this is a stone over here, then you will see partly stone is brighter, followed by shadow. Followed by shadow. It could be singular, it could be multiple. What else? That means characteristic of stone. Echogenic foci with posterior shadow. Singular or multiple. Change position. With the change of patient. With the change of patient's position. Then free in the urine. That's why it is changeable. But sometimes some stone can be stuck with the wall. Then you will see shadow is there, echogenic foci is there, then it's not freely movement. So if it is not freely movement, then you might think that it could be a polyp, it could be a mass, or it could be a stone. Now, question, how are we going to differentiate this is polyp or no polyp. This is a mass or no mass. This is a stone or no stone. Give me the clean 2-3 differentiation.
It's brighter.
If it is a polyp, what is the characteristics of polyp?
It would be less.
No shadow, homogeneous, pedunculated. Click the color, feeding arteries. And it is one end free, another end attached with the wall. Then mass,
Also
it is attached, irregular border, heterogeneous with necrosis, and you might see the blood clot inside. And patient will give the history of blood or blood clot. If it is stone, stone say fixed with the wall, it will be echogenic with shadowing. If it is a free stone, it changes the position. You click the color with on the stone, you will see the no color. But these two, you will see the color. So easily we can differentiate.
Can you get bladder sludge just like you get in the gallbladder?
Usually we don't call bladder sludge, we call it debris.
Okay.
Debris. Okay, so now I will go with causes of bladder outlet obstruction. So they will ask 2-3 questions from this because those are the maximum sign symptoms with the patient will come to the doctors. Bladder outlet obstruction. Causes of bladder outlet obstruction. Number 1, in children. In children, posterior urethral valve, PUV. What is posterior urethral valve? See, this is PUV. This is bladder. This is urethra. It is congenitally present. And baby is trying to pass the urine, but the gate is closed. Prognosis is good. The urologist, they will insert the cutting scissor, they will cut and clean it, and the problem is gone. Now, for old age, most common cause of bladder outlet obstruction means bladder neck obstruction is posted BPH, benign prostatic hypertrophy or prostatic cancer, prostatic cancer. And this is always male fetus, male. This children is male. Okay, old as BPH. So what are you going to see? Then you will see the prostate gland is enlarged. What else? PSA, prostatic specific antigen, is high. What else you gonna see? The bladder wall is thickened or presence of diverticulum. Okay, and number 3, neurogenic bladder. Neurogenic bladder means imbalance of autonomic nervous system, sympathetic and parasympathetic in coordination. Okay, you got in short a thorough knowledge about the bladder, right? This is a very good lecture. Now, protocol. What is the name of the protocol to evaluate the bladder? We need to evaluate pre-void and post-void residual volume. Bladder evaluation. In bladder evaluation, we have to understand that bladder must be full. We need a full bladder, right? And this full bladder, we need to check that full bladder. We will do the protocol images, just a few protocol images, both in sagittal view and transverse view, right? And in sagittal and transverse view, we will measure the length and height. In transverse view, we will measure the width. But we need a full bladder. Full bladder, I will say, before voiding. Before voiding, can we say pre-void? Yes. Before voiding means pre-void. So we need pre-void, length, height and width. This length and height we will get in sagittal view, width in transverse view. Right? So now this length times height times width divided by 2, we will get the pre-void volume. Pre-void volume in cubic centimeter. Right? So, example, pre-void volume we got 500 cc. Pre-void. Okay? So now I will ask patient to empty the bladder. Why? I like to see the post-void residual volume. So ask for voiding to see the post void residual volume. What is post void residual volume?
If there's any more.
Yes. Suppose that I completely empty the bladder, I should not have any urine in the bladder, right? But still there are some amount of urine. That is called post void residual volume. You got it?
Mm-hmm.
So now, calculation of post void residual volume. Keep that in mind. Normally, 20% of pre-void volume pre-void 20% of pre-void volume is taken as normal for the individual. If post void residual volume is greater than 20% of pre-void volume, it is pathological. It is pathological. So now I will teach you how to calculate the post-void residual volume. Say, I told you the pre-void volume was 500, right?
Mm-hmm.
And I asked for voiding to see the post-void residual volume. I found this is 100 cc. So now, calculation is post-void residual volume equals post-void volume of the bladder over pre-void volume times 100. So now post-void residual volume, post-void volume we found 100 and pre-void was how much?
500.
500 times 100. So now you can easily divide it 5 and the 5 is 20. So now 20%. Then still we will say, okay, bladder is working good. Right?
Mm-hmm.
If the patient come back after voiding that and I measured the post-void volume is 200 cc. So then I'm going to use 200 over here, right? So now then I will cross it out, this 0, this 0, this 0, this 0, and the 5 is on the down, so I will, this 5 and this 100 is 20. So now 20 times 2 is now 40. And I will see, oh my God, this is greater than 20%. Why is this? Because the bladder has no energy, no potentiality to contract strongly to empty the bladder. So this post-void residual volume is 40%, indicating that patient is not capable of voiding completely from the bladder. So normally maybe 5%, 10%. Some patients, some people, they void completely. Completely. So that is the thing that we need to do in bladder evaluation. Okay? You got it. So bladder is done.
That was fast.
Okay? And this is for me.
Oh, thank you.
Okay. We'll talk now suprarenal gland. Another name is adrenal gland. Another name is suprarenal gland. Why it is called suprarenal?
It's over the kidney.
Yes, supra means superior. It is on the superior upper pole of the kidney. Why it is called adrenal gland? Because it produces adrenaline and non-adrenaline hormone. That's why its name is adrenal gland. Okay, how many are there? Let's talk about the anatomy. Then we will talk about the physiology. Then we will talk about the embryology. Then we will discuss about the function. Oh, okay, physiology. Pathology. Okay, anatomy. There are, okay, two adrenal glands. Two adrenal glands. One on each kidney. Right adrenal gland is pyramidal shape. Left adrenal gland is semi-lunar shape. Both are covered by gyrotous fossa along with kidneys. Okay, and it has outer cortex and inner medulla. Outer cortex has 3 zones. They are developed from the mesenchymal cells. Inner medulla arise from ectoderm, that is called neural crest cells, then chromaffin cells, then pheochromocytes. It arises from the ectoderm, then ectoderm that converts into neural crest cells, neural crest cell to chromaffin cells, then finally pheochromocytes. Okay, so I'm going to erase this. Now, blood supply is very important. If I draw the diagram, okay, so this is right, it's triangular, and on the left side, semilunar. It may extend up to the hilum of the kidney. Okay, and both of them are covered by gyrotous fossa. Okay, this is gyrotous fossa. Gyrotous fossa. So these adrenal glands are highly vascular. The arterial supply comes from a direct branch of aorta. Adrenal branch